you all for coming and joining us for our talk, Don't Tell My Family, Understanding the Impact of Cancer Stigma. We have a live audience that's here, so if people have questions during the talk, feel free to raise your hand. Otherwise, those of you that are joining us from around the world on Zoom, please post your questions in the chat and we will grab them and make sure that we answer them for you today. So I'm Kristin Schroeder. I'm a pediatric oncologist here at not Buganda right now. I spend half of my time at Buganda Medical Center in Tanzania. And I am with two of my colleagues today. Unfortunately, Dr. Nosa was unable to join us. So there are two of us that are here today. And Dr. Brandon Nettle and Suhana Kosani. So I just want to talk a little bit about some of the logistics for today. So we will have time for Q&A after the panelists both all have a chance to speak and present their topics. And this talk today is going to be recorded and posted publicly. So just make sure that everyone knows that comments and things that are put online may be seen by others. Thank you. So the topic today, what we are talking about and why. Cancer stigma, as people know, is a negative attitude or belief about individuals who have been diagnosed with cancer specifically. And that can lead to shame and isolation for people who have been diagnosed with cancer. This can discourage people from seeking out help. It can discourage them from coming to be screened because they don't want to know the diagnosis. So many people think all over the world that cancer can be caused by personal behavior only, by lifestyle choices. And as a result of that, that brings on a sense of shame sometimes. And that sense of shame prevents people from wanting to know if they're diagnosed. So they don't come for cervical cancer screening, for example, or colorectal cancer screening, prostate cancer screening, things that we know we can do to help prevent and reduce death. If healthcare providers have these negative attitudes and beliefs, which is also very common, people think that cancer can't be cured, they're less likely to give aggressive treatment to patients who are diagnosed with cancer when they come to their clinics. And because of many cultural norms and things that are very common around the world, cancer survivors often feel stigmatized, maybe because of the cancer treatment. They may have hair loss, they may have missing limb or eye or other things that are an outward expression that they have gone through this treatment. This can lead to a lot of social isolation, mental health, depression, anxiety issues that patients may face. And if you compound this in low and middle income countries and places that have more difficult to access healthcare, this is magnified. Because in addition to kind of the stigma and the cultural pressures to not treat this, they also have to battle being able to get to a hospital, reduced access, the cost of seeking care. All of that compounds and magnifies this issue. Our panelists today have been doing stigma research in Tanzania specifically in different areas. But really many of the concepts and things that we're going to talk about today, it's not isolated to Tanzania. These are things that are seen around the world. They're things that are seen here in the US as well. So I want to introduce our two panelists in a moment. So Dr. Brandon Nettle is a licensed psychologist and assistant professor at Duke University School of Nursing and here at the Global Health Institute. He specializes in global mental health, health behavior research, and then here many of you may know him. He teaches a course in global mental health for the master's students at DGHI. And Suhana is a second-year student in the Master's of Global Health here at Duke, and she completed her field research and thesis on the impact of stigma and different types of stigma experience for childhood cancer survivors in Mwanza, Tanzania. So I'd like to ask each of them to kind of provide an overview of the research that you did, the general topics, how you went about evaluating stigma, and we'll talk in more details about the results of that research. So Brandon.
Yeah, so excited to be here today and to talk about this important topic. Sending apologies for Dr. Osazuwa-Peters, who has a sick child and wasn't able to join us today, but he and I work on our project together, so I'm hoping I'll be able to represent his part of it as well. Nosa had the idea of exploring cancer stigma in Africa, and I had a lot of prior experience working in Tanzania and at Moshi, and so it became a good site for our work. We enrolled a cohort of 154 people with a new cancer diagnosis and administered first a quantitative survey to understand a lot of different aspects of their personal characteristics, demographics, mental health variables like depression and anxiety, experiences of stigma, of course, which is mostly what we'll talk about today, and then their experiences with care engagement, to kind of understand whether some of those personal variables, mental health variables, stigma variables impacted their care engagement. And so care engagement meaning their kind of time from onset of symptoms to the first time they presented for care, but also delays once they reached the healthcare system. Found some really interesting things there. As part of that, we asked 3 qualitative open-ended questions at the end of the survey related to people's beliefs about the experiences of cancer stigma that people might face, the impacts of that cancer stigma on their care and care engagement, and then ideas for how we might address cancer-related stigma. My master's student, Judith Mabobia, did her thesis on that project, recently defended it, and it's done a really fantastic job with qualitative analysis on that work. So she's done an incredible job with that. And then also we did a scoping review of studies related to cancer stigma in Africa broadly, in the whole continent, and Savannah will tell us a little bit more about that. She's been involved with that too.
Thank you. Thank you all for coming. My name is Savannah. Like Dr. Schroeder said, I'm a second-year master's student here, and I was lucky enough to be paired with Dr. Schroeder first year as a master's student. And I was really interested in the research that she did in Tanzania because she's really interested in looking at systemic barriers to cancer care, which is something that I'm interested in researching. And so when I joined on her project, she had this prior knowledge of cancer stigma, which is something that I wanted to be involved with and research. And so when we were developing the project, I was really interested in doing a qualitative research study. And so my research project in Tanzania was doing qualitative interviews with pediatric cancer patients and their caregivers about the community stigma they experienced before coming to treatment and while they were receiving treatment. And so I'll talk about the findings a little bit later, but we kind of just found that generally that pediatric cancer patients and their families experience some stigma that adults also face, but also there's specific stigma aspects that they experience that are like more specific to children and cancer care in pediatric patients.
About the scoping reviews.
Yeah, and so I'm also working with Dr. Brandon Nettle on a scoping review of like pediatric cancer care in all of Africa. And that is actually it has turned out to be quite a small study, just because we thought in the beginning we had all these papers that talked about cancer stigma, but as we kind of looked through each study more in depth, either they didn't really include children, or like they had like maybe 1 or 2 patients who were under 18, but most of the patients were over 18, or they didn't really fall into what we consider as pediatric cancer stigma. And so we end up with kind of this really small collection of studies. I think we have about 12 that discuss pediatric cancer stigma. And they're from countries all over Africa, but the themes are quite similar among all the studies. So that was really interesting as well.
And there are a lot of different types of stigma. When we talk about this, there's the perceived stigma. So what people believe, others are avoiding them, or awkwardness that people feel being around someone who has cancer. There's financial stigma. There's both perceived and experienced. So if someone, it's more challenging for them to seek care because of a specific diagnosis, that could be a societal level barrier for stigma. So I'm interested in what types of stigma did you guys find were most prevalent in your studies?
Yeah, so we, the first paper we did based on this cohort of 154 was to do a factor analysis of a lot of stigma items that we administered. And so we took stigma items from existing measures and asked people whether they had experienced those types of stigma, and tried with our study team before the study to come up with additional stigmas that might not have been covered in some of those existing items based on what we knew about other experiences of folks in Tanzania. Some of this was drawn from prior studies on mental health stigma, HIV stigma, trying to kind of apply those frameworks, which were a little more established, to the cancer field, which is much less established in terms of cancer stigma. And then some of the items that folks on the ground there kind of thought might occur would be beliefs that cancer was contagious, beliefs that it had a spiritual component, like it was a punishment for wrongdoing, or some sort of curse, or kind of punishment from God for wrongdoing, or even from your ancestors that you had acted in a certain way and this was a form of punishment, items like that. And so we kind of administered all these items and then saw how they came out in terms of people's experiences of cancer. We saw a really interesting dichotomy between those items of asking people, have you experienced this type of stigma, and our qualitative work, in that the items were really not endorsed very much, that people were pretty hesitant to say that they had experienced stigma, whether it be kind of more internalized or externalized stigma. And so the levels were lower than we anticipated. But then when we asked people in an open-ended qualitative way, those items were phrased differently, which was, how do people living with cancer, how are they treated by people in their community? So it was not about how are you treated, it's how are people with cancer treated? And when we asked it in that way, that was depersonalized a little bit. That was intentional, right? To kind of see if people would open up in a different way. And they did, right? They talked about people with cancer are mistreated all the time. They experience all of these different forms of mistreatment, stigma, alienation, social isolation. And so even though they weren't really willing to kind of endorse those quantitative items as much as we expected, the qualitative stories were very rich and very robust when they talked about cancer as a whole. But as far as types of cancer stigma, in this factor analysis, you throw a bunch of items at people, and the analysis talks about how they group out. Like, are there groupings of the ways that people respond to certain items? And we saw 3 that were really kind of reflected in a lot of existing frameworks. So internalized, which is feelings of shame, self-blame, sadness that are really about yourself and your own experiences. Enacted, which is how other people treat you in like a actually enacted behavioral way. People avoid me, people gossip about me, those sorts of enacted stigmas. And then more of a kind of community level stigma, which some would call like an anticipated stigma, like if people knew they might mistreat me, or people out in the community kind of might feel this way about me, even though I haven't kind of directly experienced it. And so in HIV frameworks, we would call that like anticipated stigma of what you might experience. In this framework, it was a little bit more of like community level, vague, kind of out there, people mistreat people like me. But then the 4th one that emerged that we hadn't seen in prior frameworks was much more highly endorsed than the others, and it was specific to disclosure. So I'm concerned about disclosing my cancer to other people, or I hesitate to disclose my cancer to other people. So even though they weren't kind of endorsing these items saying, I have been mistreated, it was like, but I'm still not going to tell anybody because I'm concerned I might be mistreated. And that disclosure piece really emerged very distinctly for cancer in this setting. So that we found to be really interesting. And if we were to do it all over again, we'd ask a lot more questions about that kind of disclosure piece. And it might have a lot to do with kind of the collectivistic nature, the kind of social ties that are so strong in this setting. So we're really kind of interested in exploring that more.
On the pediatric side, what sort of themes emerged for you?
Yeah, so we actually had a lot of overlapping themes, a lot about like the aspect of disclosure actually was really important. So with the study that I did, we had different age groups. So the first age group was like very young people, so kids to age 13, and with that age group, we only talked to caregivers. The next age group was 13 to 18, and then the last was 18 plus. And so a lot of the disclosure issues were actually brought up in the 18 plus group, where like 18 plus patients who had been treated and were like, quote unquote cured, they talked a lot about how they actually didn't tell anyone even after they were cured. So, you know, multiple people said they only told their parents, or the only people that knew were their specific caregivers. And so that was really interesting that I was really anticipating. But again, similar themes, anticipated stigma. People talked about how they didn't go to certain events or attend class because they were afraid of what people might say to them if they found out they had cancer, or if they saw the effects of the treatment, like their hair loss or like, injuries and like that. One aspect that was different in the pediatric cancer studies that I found as opposed to the adult studies was specifically teasing in school and among schoolmates. And so a lot of the younger patients talked about how they didn't want to go to school or were afraid that when they were in school, their classmates would see the effects of the cancer treatment specifically and tease them about that. And parents kind of echoed the same thing, that their child would say that they didn't want to go to school or that they didn't want to hang out with their friends because of these kind of effects of teasing or bullying in school. And yeah.
Kids going through middle school and things here, it affects everybody. When you have someone who comes in who looks very different to you, you're immediately kind of drawn and they become a I think I've talked to parents and told them some of the results about people being bullied who have either experienced cancer or who've had children with cancer. And here it's always a shock that people express, right? It's like, why would someone tease a child who has cancer? But there, it's not just, here there's more empathy, I think, for someone who's going through that. Part of that is because we have a higher maybe health literacy and a higher appreciation, understanding of the fact that there is no cause for many of particularly childhood cancers and most adult cancers, 40% of adult cancers. And so I think there's more empathy here, but in the experience in Tanzania and others, how do you think that kind of played into the education or the community knowledge or awareness in that perceived stigma and fear of disclosing their diagnosis?
Yeah, very good question. I'm thinking about severity a lot. And so I think part of it is that the people who were in cancer care, the vast majority had stages 3 and 4 cancers. So very severe cancers, maybe not the greatest prognosis. And so I think there was a very strong association of cancer with death. I know there was, because that was one of the predominant themes that emerged in our qualitative analysis, that it's a death sentence, and that and the financial literacy, the financial piece comes into this too, that there was a perception of cancer. If you get cancer treatment, you'll bankrupt your family because you'll dump all of this money into treatment, and then you'll probably die anyway. And so it's a really kind of terrible statement. Like you'll bankrupt your family and then you'll probably die anyway. And so that overwhelming negativity around it just kind of pervades the attitudes of both the person who's in cancer treatment, their family, and their kind of broader support system. Whereas I think here, we often respond to cancer with a sense of hope. And part of that is because maybe treatment's more likely to be successful. And maybe because the financial burden, of course, it's still here in the US and in other kind of settings, but the financial burden with health insurance and other kind of support resources might not be so great. And so that kind of negativity around the financial piece and poor prognosis, I think, just creates a feeling of dread that sometimes gets really mixed in with the idea of stigma and mistreatment.
Yeah, I think also there's not many cancer care centers in Tanzania versus here. I think like most hospitals have like some sort of access to treatment. And so I think that kind of that low access to treatment generally in the country, like people have less literacy there because there isn't that many treatment centers as well. So maybe people, if they get these symptoms and go to a clinic nearby and they're not near a cancer treatment center, they might not know that. We also saw very similar themes. People, didn't want to pay. People would tell caregivers they shouldn't pay for cancer treatment because child would die anyway. We also found that among caregivers, sometimes one parent would just kind of leave. Like the father or mother would be like, I don't think we can afford this. Like, I'm not sure if the child will die. So you want to take them in, that's fine, but I can't really say that. Which was also kind of a really interesting thing.
We've seen that a lot, where it's not just about getting the patient to treatment, it's maintaining and finishing the treatment. And a lot of what is influencing that is that kind of perception, that community chatter that's telling you, why are you doing this? You're going to die, or your child is going to die. Why are you spending this money? This is something that is not curable. This is something that is not curable by hospital medicine. And a lot of what we see is people seeking traditional healers and other care, because the interpretation is this is not curable. And I know in pediatrics, in the US, 85% of childhood cancer is curable. And in Tanzania, we are about 50% of childhood cancer is curable. So the barometer is changing in that conversation, and hopefully reducing stigma in the future, particularly about that curability, I think is very important.
Yeah, I think too, like in a setting where health insurance is still fairly rare, and treatment is often fee for service, that you pay up front for a surgery, you pay as you go for chemo, that there is an informal system of loans amongst your social network, that you approach a family member and say, hey, I need this surgery, it's going to cost this much, I'll pay you back over the next year, and that's, well, that's common. But those same family members, if they perceive that you're not likely to survive, then they either say no, or they might actually avoid you in order to not have to say no. And that was a common experience of people just disappeared because they were afraid that this would have a financial burden on them. That financial burden carried over into work environments quite a lot too, especially of people who were in jobs that were involved physical labor. It was like a perception that I'm no longer going to be capable of doing the work. And so I lost my job, or I'm not going to tell them because I'm afraid that I'll lose my job, that they'll perceive that I'm now physically incapable of doing the work. And so concerns about work-related stigma and being able to continue to support the family because you're missing a lot of time off work to pursue treatment, or just because you'd be physically unable to continue to work.
One of the things that I have seen is that if the treatment is going to involve something that physically alters, right? Removing of the eye, amputation of the leg, or something like that. We've had many families who have chosen to not do surgery or disappear right at that point. Some of it is financially motivated, and some of it is the fear of having a child or becoming unwhole. And did you guys, I'm wondering in the conversations and the data, did you see if there was a difference in someone who could perhaps hide their diagnosis more easily if they experience less stigma or perceived less stigma?
In the qualitative work, we saw a little, but less than we expected, honestly, in terms of gender differences. We expected to maybe see more themes emerge around masculinity and femininity, particularly around breast cancer or OB/GYN cancers, or for men, prostate cancer, or things that might kind of be impacted to affect sexuality or masculinity. It emerged less than we expected, and I was kind of surprised by that. For us, kind of these larger themes of worries about the social impact were more. We didn't ask specifically about visual deformity or about this masculinity, femininity question. So maybe if we had asked about it more directly, we would have seen that emerge more. But in these kind of broader open-ended questions, it emerged less than we anticipated.
Curious from some of our audience members, online members who've done We're not the only group who is doing stigma research here at Duke, right? And Megan Heshkos and others, and there's a group in Singapore who are also doing research, breast cancer and cervical cancer. Curious if audience members questions later, if they have experienced more of that than what we may have at our site. If you did the parents mention anything, or did you notice anything with perceived stigma for ones who had maybe more visible outward appearance?
Not specifically. And again, with the focus groups, like when we did the focus groups, we didn't kind of separate the responses, but I think also with kind of the way we sampled and the people who were willing to come in, those specific patients didn't have like as severe symptoms, or like, I don't remember anyone like having amputated legs or anything like that. So I think maybe the way we sample, like we did like maybe capture all of those patients who might have experienced that.
Yeah, that emerged a little bit for us too, in that we actually excluded people who were bedridden, who were kind of so ill that they would have had a challenge completing the survey. And then we were recruiting from the clinic. So people who couldn't have made it to the clinic at all, or people who disengaged from care because of stigma. There was a lot of folks that we missed, and maybe those were the most severe folks. And we might have found very different patterns emerge if we had gotten that kind of more severe cohort.
So I want to shift a little bit, because one of the things that was mentioned before was sort of disclosure, stigma around disclosing, right, among all age groups. And that brings to mind a lot of the HIV stigma literature and some of the interventions that were done specifically targeting that stigma, right? People were afraid to get tested because they didn't want to know the diagnosis, and then no one wanted to be open about it. And I think we've seen a little bit of a shift in that recently due to a lot of very effective strategies, both from media and communication health strategies. Curious how you guys think that the research and all the work that was done for infectious disease and for mental health is sort of influencing how we're talking about or thinking about cancer stigma.
The area where we noticed probably the best progress in that space was around HPV and cervical cancer. And so in the scoping review, we found 98 studies ever conducted on cancer stigma in the continent of Africa. So, 98, it's a fair amount, but, that's an entire continent ever. So maybe smaller than we would expect. Among those, a lot were kind of early stage exploratory, like what does cancer stigma look like in this setting? Or what are some predictors of cancer stigma? So very kind of early stage exploratory. Notably, only 2 had any sort of intervention component, and those were both brief educational interventions, and both were related to HPV and cervical cancer screening. And so that was the only 2 interventions we found in the entire continent related to cancer stigma specifically. And so if we break that 98 down, so and I mentioned like 12 were pediatrics specifically, and among those remaining 86, about half were cervical cancer and HPV specific. So, I mean, think of all of the cancers, and about half of them were on that specific topic. And so I think that's exactly what we're talking about, that kind of attention that's been paid to reproductive health in the continent related to HIV, et cetera, has started to pervade HPV, cervical cancer screening treatment. And then this entire other swath of other adult cancers is just basically untouched with 0 intervention and very few studies.
I think one of the things that we've seen is because of all the attention and the focus and the shift from HIV kind of into HPV and cervical cancer, and then by proxy, kind of if you're doing cervical cancer screening, breast cancer screening, they often do it at the same time, is that many people believe on our side for pediatrics that children can't get cancer because the discussion, the topic, everything is about adult cancers. And so then there becomes this perception in the community that kids can't get cancer. So if they do, they must be bewitched. They must be cursed. There is something that happened, which then drives more of the stigma in the community of don't bring the child in, don't get treatment for them, go to see a traditional healer or someone else. Your family has done something wrong, bring shame to the family for having a child who is diagnosed with this. So people don't want to have the diagnosis. We've had people who have been told that they have a tumor, but it may not be malignant. And in their mind, that's a celebration because having a mass is something that people can have. But if we call it cancer, then that is a curse, and that would be change the way the community looks at that child and the family.
Yeah, a lot of the stigma in in more developed countries and other settings outside of Africa often focuses on lung cancer because it's the one that's most often perceived as having a behavioral cause. And so even the measures are often derived from lung cancer in the US or lung cancer in Europe. And we see a lot of those same attitudes across different cancers in the African setting, that it's perceived as you caused it, even if there isn't kind of that direct kind of how, right? Like, how did I cause it? So yeah, and Judith's thesis is literally called "Let Him Die, He Caused It." And that's the sort of the title of her thesis, because of a man's brother, a man with prostate cancer, his brother said, let him die, he caused it. And again, there's no way that they could describe how he caused it, but that's just a common perception that if you get cancer, somehow it was due to your own negligence, behavior, et cetera. And that leads to a lot of mistreatment among family members and others.
That was something that you found as well, or was discussed.
Yeah, typically like religious affiliation or bewitchment, or like one of the patients or one of the caregivers talked about, one of the people in the community said that someone else had cursed them. And when they tried to ask me, you remember like who did this? Like, it was like, oh, I don't know, but something cursed you. So stuff like that. It's like, how do you even kind of respond to that?
Yeah, there isn't an answer, right?
Yeah.
No one can tell you what caused it or what it is. There's no intervention or thing that you can target it. So sort of thinking about that, so many of these things, there isn't a scientific explanation, A to B to Z. How do we tailor, how do we create interventions or things that we can do for some of the different types of stigma that we have seen and potentially different time points, whether it's at diagnosis, completion, survivorship? Right, did you guys recommend or think?
Stigma is notoriously difficult to intervene with because these cultural attitudes are very embedded. They come from childhood, they come from really deep cultural roots. And so it's a difficult question to answer. In our stigma work, we often, in looking at intervention, and even the two that we did find, you can change knowledge. And with an educational intervention, you can help people to be more knowledgeable about maybe the causes of cancer or cancer more broadly. And then when you try to measure, okay, did that knowledge impact your stigmatizing attitudes? Often it doesn't. Like, that's much more embedded and difficult to change. And so I think we maybe start with knowledge. That's a great starting point, like expand cancer-related knowledge to the community, because that maybe is a necessary but not sufficient, way to kind of intervene. But then I think it's going to be prolonged engagement with different attitudes. Like, we need to really fundamentally introduce a different way of looking, and that's been successful here in the States, I think, and in the other settings that I'm familiar with, where the cultural tendency when somebody has cancer is to like come in and provide support and care and hope. And I think we haven't done nearly enough to incorporate a lot of those things into health systems as we expand cancer care internationally. So understandably, the first focus has been, let's get access to radiation, chemo, right? Like to modern treatments, like absolutely. But here, for example, that's immediately accompanied with support groups, social work, all of these kind of supportive services that are provided around cancer care that, we've come to understand is really vital to people's outcomes. And that's largely absent in the places I've worked internationally, where you get the care, but a lot of those supportive services around it are absent so far. And there's so much opportunity to expand those out, whether it be mental health care, social work, et cetera.
Areas or ideas that you can think of that would be potential interventions?
Yeah, so similarly to what Dr. Nettle said, both in the scoping review and the research I did for my thesis, there was little to no interventions in the cancer space. The one intervention I found was done in South America. And the researcher had developed like a school play to perform in schools about cancer stigma and about cancer and the symptoms. I think that would be a really lovely intervention if it could be incorporated into school like education, so that kind of hopefully some of the stigma that adults are seeing could maybe be lessened like through the education of children as they kind of grow up.
Be the next proposed intervention.
Perfect.
Creating a school-based education program, so nail on the head. What questions does the audience have, or people who are online, that we can, talk more in depth about some of these topics? Yeah.
Hi, thank you for the talk. I'm really glad to see cancer stigma on a forum today. So my question has to do with stigma itself, the word, right? It's not translatable in many languages. I don't even know if it's translatable in Swahili, maybe a phrase, maybe a bunch of phrases. It's definitely not no, we definitely can't, it's hard to capture the accuracy of that word in regional indigenous languages. So how do you navigate that in your research?
Yeah. Got it. Thankfully, there is a word, right? Swahili that translates fairly well to stigma. So we use one word and it's pretty well understood. And then we're always in this study administering our items face to face. So it's not just handing a paper survey to somebody and hoping they understand it, but actually verbally administering the surveys, and that helps so that if people are confused or have clarification, we can provide it. But there is a Kiswahili word that translates fairly well.
One of the things that we've done too, when we're creating these surveys, which was working on one as well, is we don't say this is a stigma survey. We're asking about the different areas that are considered part of stigma. So that awkwardness, that avoidance, the financial policies that are in place. So we ask questions about those things, which translates to what we know is under stigma. So in areas that don't have a specific word. But that's a great thing to think of, particularly when you're creating surveys that are like using the term, right? It's hard to say, do you have any stigma? You can't ask that. You have to say, has anyone turned down a job if they knew what your diagnosis was, or how has this influenced disclosing or telling people in your family and friends? Online question?
We have 4 questions, so
Start one.
so good luck, who's a medical student from Tanzania, asks, what are some of the current strategies used to combat cancer stigma in USA, and how can we transfer that to low and middle income countries like Tanzania?
Hi, good luck. What do you think, Suhana? What would you say?
Yeah, that's a pretty tough question. Like Dr. Nettle had mentioned, most of the cancer studies that are done in higher income countries are focused on lung cancer, which again is like cancer that's people think specifically has, like the person has a role to play in the occurrence of their disease. So I'm actually not really sure. I'm sure there are studies that do have interventions that focus on, I would assume a lot of them focus on now like increasing knowledge of how like different cancers come about. So maybe that could be kind of like a knowledge-based intervention.
Yeah, the different ones that have sort of been used here are exactly that. So it's knowledge-based and then community sort of media-based, right? So it's targeting the community, understanding what the current beliefs are. They're in a specific community, gaps, knowledge, kind of the attitudes, perceptions, all those things we talk about, our CAP surveys and things. There's a reason we do those, and that's to get a temperature of the community that you want to go in and provide education for. And that can be for an individual city, that can sort of be for a country, or that can sort of be for an age group, population, kind of universally. But it's helpful to have it adapted. And so there are things in the US, there are TV campaigns, radio campaigns, ad campaigns, that are some in the cancer area, but many are in other health interventions, right? Stop smoking, vaping, all of that you see on the TV right now, kind of targeting messages to young population. So it's just using those different health education strategies. And then adapting them to target the specific beliefs or the specific perceptions that exist that lead to that stigma in a community. I think it's
Yeah, this is also a setting where we have more mental health providers. And so I think stigma gets incorporated into that mental health work more broadly a lot more often in cancer centers here. And so support groups or individual counseling, where if you do have a physical deformity or loss of function or capacity or any of these things, it's kind of a part of the counseling that you receive in those support groups or individualized counseling. So maybe more integrated into mental health more broadly of what has it been like to live with cancer, to cope with, to go through treatment, to move on to survivorship. And then if stigma emerges as part of that, it's kind of treated as kind of part of the full mental health or support package. And I would love to see that in Tanzania. As of 2018, we didn't have a single psychiatrist at KCMC. And since 2018, through some really generous grant funding, we now have 3 and 3 more in training and a new dedicated building for mental health and psychiatry at KCMC. So in the last 5 years, we've seen this rapid expansion of mental health as a priority and a lot of resources being put into the area. And I'm so thrilled about that. So at first it was just like, take all comers, like who comes to the psychiatry building from the community, from the hospital, et cetera. But now I'd love to see us doing outreach from psychiatry into some of these different centers within the hospital, and cancer is like at the top of my list in that space of one of the areas where we need to have our new kind of capacity in psychiatry branching out to other parts of the hospital to provide care and support.
It reminded me of one kind of cool stigma reduction intervention that we do here in many places is when a child is diagnosed, our social worker will go into that child's school if the parents in the school agree and talk to the classmates and explain to them, your classmate has this is what cancer is. This is nothing to be afraid of. This is not contagious. This is something that happens and he's going to be, the same person. You can talk to him on Zoom while he's going through treatment. Kind of, they have a bear that you can literally put the bear in the child's seat as sort of a marker so that the class continues to think about that patient and the patient feels that they have a presence still with their classmates and colleagues. So just other interventions that are kind of out of the box that you can adapt. There was another question that was here. Yeah.
I know you mentioned earlier that in the US about like, I think 80% of cancer can be treated, or was a higher percent. Does that include like stage, is that like stage 1 and 2, or does that also include stage 4? Because that's something I don't know much about cancer research out there. Like can stage 4 or 3 be treated in the US?
Yeah, so for childhood cancer specifically is where that came from. It's over 85% cure rate, and that's overall for all types, all stages. So there are, the difference being that in the US, more of our patients come at an earlier stage because they are diagnosed earlier. There are certainly many diseases that even stage 4 can still cure. There are some that make it very hard to do so. That shifts when we're talking about in Tanzania or other low resource countries where more of those patients come at the later stage. And here, when you do have a more aggressive cancer, we can use some fancy technology and chemotherapy and things that we don't have as an option there. So that's why our survival rate is about 50%. And with capacity development and reducing treatment abandonment and other things, that number will go up with time. The worldwide goal is to get to 60%, and that's sort of the perceived, based on current capacity kind of globally of where we can get childhood cancer. But yes, it's much higher than people perceive.
In our cohort, we found that there was a year-long delay from onset of symptoms to first treatment. So that's unacceptable. And sadly, about half of that was from time of onset of symptoms to first seeking care. So about 6 months on average of waiting after you'd already experienced symptoms before you sought formal medical care at all. So it's kind of person level, community level. But then the other half was medical system level. They had actually sought out care and had another 6 months of delay in getting pass from facility to facility, getting an appropriate diagnosis and starting treatment. And so both of those have so much area of improvement of helping people to recognize symptoms and seek care early, but then also making sure that the health system responds appropriately and quickly once somebody's presents with symptoms to get the appropriate diagnosis and treatment started right off. So yeah, that is a huge contributor to why people are so late stage by the time they're in treatment.
And second question is from Professor Kirsty Stewart. She asked, have you collaborated with traditional healers to address some of these stigma and misinformation issues? If yes, what was your experience? If no, is it worth trying?
I have it. I don't know if you.
We haven't yet.
So we actually just recently did that in that amongst our patients, the vast majority initially present to either a traditional healer or a community health worker who's local in their community. That is the first point of contact when we looked at where people came into the health system and then kind of where they went from there. The vast majority, I think it was 80–90% of them started there. So we recently did an education that was specifically for traditional healers and community health workers in a specific area around Mwanza. And one of the first things that they said was, thank you for including us, because so many times we dismiss this entire group of, I mean, they are part of the health profession, right? They have different training, but many of them, there is a whole organization, there's a whole report to the regional medical officer, there's a whole infrastructure for traditional healers in many of the countries that we're working in and living in. And so recognizing them as an important part of this health system is key. Also, because that is the first point of entry, it's important that they know what the signs are of cancer, that they know there's treatment for this. And also just to sort of talk about some of the challenges and delays, right? So that they can be better educated. And many of them were appreciative and wanted to learn about that. They recognize what their boundaries are and when they can't cure something, right? And they want the patient to be treated. There's always some exceptions, but the vast majority, that's the intention. So we have, and I don't know if you guys have plans or.
Not formally, but I will say that kind of openness, willingness, acceptance of traditional healers as part of the health system is fairly new. And so we're fighting against a lot of history there of kind of this colonialist tendency to villainize and exclude traditional healers from the health system in a lot of ways. And some of that's religiously driven, that they're perceived as kind of a separate, almost in conflict with Christianity and some other, and the religion in the community, that it's like an alternative to that. And part of it is that a lot of the health providers training very aggressively talks about traditional healers as frauds, charlatans, that the medication they provide is dangerous and unregulated. And so when we talk to nurses, for example, and this is carrying over some work from HIV and mental health in this context, is that the nurses will off the bat say, like, we don't want anything to do with those frauds, those charlatans, they're, awful people and da-da-da-da-da. And then you'll kind of get to know them a little better and you'll say, well, have you ever seen a traditional healer? Do people in your family see a traditional healer? And they'll be like, oh yeah, absolutely. And so you'll learn that it's a statement of almost telling us, folks from outside who might be perceived as part of the medical establishment, telling us what we want to hear. Like, oh no, we would never engage with those folks. But then when we present it as, well, might that be helpful? Might those be individuals we'd want to engage with? Might that be kind of part of the health system? They'll be like, yeah, actually it is. And so it's maybe breaking down some of that historical, like, open tension between traditional healers and the formal health system. And that's going to take some time, but I think there's a lot of potential there as that becomes more of an option.
Other questions? Sure.
So obviously you found the people that you included in your surveys and your interviews from the cancer treatment centers, or of which there are very few. Do you have any idea what the unknown is? Like, there aren't very many cancer treatment centers. Cancer is a global, huge burden of disease problem. Do you know, like, are you going to be able to solve problems without massively increasing access to care? do you know how many kids aren't being treated, and do you know what that is because of stigma, or do you just sort of, it's a black box at this point because it's kind of new research?
Yeah,
Yeah, there are estimates. There are very broad estimates. I think it's 134 cases among 1 million, maybe, for pediatric cancer.
There for 100,000, yeah, so 400,000 estimated globally. And then in Tanzania, it's about 25% of patients actually come to one of the treatment centers across the country.
But you don't really know yet if that's just an access, a financial issue, or if it's a stigma, or it's a big old mix of all of that.
Yeah, all of the
Yeah.
above, exactly. And so I think it's a really a both and scenario. Like, we certainly want to continue to improve access to treatment.
Mhm.
But we also don't want to neglect all of the supportive services around it in the interest of all we need to do is like get access to the treatments, right? And so I think we can do both. We can do both at the same time of addressing access to treatment and modern technologies, while also trying to understand and address the cultural aspects. I mean, systemic, cultural, the whole ecological system that prevents people from accessing those services when they are available, or making them more accessible.
And if you had access at stage 1 or stage 2, perhaps the survivability would be greater.
So Dr. Chris Vera asks, do you see issues with intersectional stigma, such as cancer stigma overlaid with gender issues in breast or cervical cancer? This is a major concern for HIV now, and an intervention focus in the field.
Defer that one to you, because you have the greatest intersection knowledge between those. We don't see it as often in peds, the exception of some of the HIV cancers.
Yeah, I mentioned it earlier that it didn't emerge as strongly as we had anticipated or expected, but I do think that if we asked those questions specifically, we would find a lot more of that. There's a team interested in doing some work around Kaposi sarcoma, which is a cancer more common among people living with HIV, that we're interested in seeing whether some of those overlapping stigmas emerge there. I do know that the mental health stigma aspect emerged very strongly, that the idea of help seeking for your emotional health and well-being is something that has historically happened in the community. It's happened amongst family, amongst friends, maybe with a religious leader, but the idea of seeking a counselor is a new concept in a lot of settings. And so to be able to empower people to understand that there are options for emotional support and counseling within those settings to kind of address that mental health overlapping stigma.
Another one?
Yeah. So Emily Smith says, thank you for a wonderful talk. Did you speak with any faith leaders in Tanzania about how to help families navigate a cancer diagnosis to try to take away some of the stigma?
Did that come up in some of your discussions about religion and using faith support?
Yeah, lots of people, when they were asked how they dealt with their cancer diagnosis and the symptoms, they turned to faith. So, either through their families or through religious leaders. And so I think that would be kind of a good way to develop an intervention, like through religious leaders. It wasn't really a formal, like, formal.
Yeah, and I don't know that that's been explored very much, right? We're talking about who can we go to in the community, who are the ones that influence the pulse of the community, and that is sort of the traditional, the elders in the communities and the religious leaders in the communities, no matter what side you are. So those are definitively the groups that need to be addressed and spoken with, so that they have the knowledge, so that when they are counseling patients and they're counseling families, they have the information to actually help them, and not just and say there's no treatment for you. We will pray, we will refer for ABC. If we're able to give them other opportunities and counseling and education about it,
there's ways that we can influence some of those discussions and reduce that stigma. I think that's a good place to start.
Yeah, we haven't talked to religious leaders yet. This was kind of our first foray into the cancer stigma space, and we just started with patients, but I think talking to family members, traditional healers, religious, and then we'd also like to really talk to hospital administrators to talk about implementation of, whether there's support internally of what to do with this, and government more broadly. So there's a lot of other groups and folks that we need to have at the table as we talk about solutions, but just talking to people about who they have disclosed to. Often if we say, have you talked to a mental health professional, it's like less than 5%. Family, close friends, we get it a little higher, but often as many as half have talked to a faith leader about the issues they're experiencing. So that's by far the most common source that people will go to and talk about cancer and their challenges with it right now. So it's definitely an important area for us to.
Any final questions? Anything else from the?
There's
Sure.
one more.
Okay.
So good luck asks again. Do you think we can use behavioral change communication principles in cancer stigma?
I chuckle because good luck is my mentee in Tanzania. One of our medical students, and maybe hopefully a future DGHI student as well. So what about behavioral health? It's sort of the main framework that we use for a lot of this discussion. I don't know if either of you guys want to.
Yeah, with the couple of minutes we have left, absolutely. Like, we need to move beyond education into how do we change behavior? How do we put that into action? And so the short answer is absolutely. That has to be a really baked into all of the aspects of intervention that we're looking at in the future. Is health behavior, reducing barriers at the system, kind of social network and personal levels, and outcomes for sure.
So just kind of few final things for everybody. Just curious what the most surprising thing is that you learned from the work that you did, and what gap would you say you think is the most important going forward? And I'll start with you.
The most exciting thing that I think I found from all the discussions was how interested people were in telling their story, not only to each other, but to people in their communities. A lot of them talked about how they would have loved to have something very similar while they were going through treatment, like having a place to kind of express their feelings and talk to other people who had survived treatment, because that would have given them a ton of hope. So I think that is a really another avenue for intervention, where these people who are interested, both patients and caregivers who have survived cancer, can go out into the communities and be like a spokesperson. So that was really exciting. And then what was this?
So like what intervention would you say?
That would be the one for both.
Yeah, I'd say most surprising for us was how intertwined the financial barrier and the stigma barrier were. I think that I had always thought of those as two separate issues. Cost of care is an issue, stigma is an issue, but people talked about how closely intertwined those two were. And so I think the intervention there kind of speaks for itself. Like, we need to support people to have more resources to support the financial aspect of care, whether that be improving access to health insurance, microfinance, et cetera, to help people fund cancer care and address that financial burden, to take that away as much as we can, so that they can just focus on getting better, which is really what we're all just.
Yeah, I think for me, the thing that probably changed my perception of everything that we do is when we actually talked to parents and community members. And I think it was more getting out of the patients who came. You'd asked about what is the gap from people who actually show up and don't. It's when we went into the communities themselves, and rather than just talking to patients who came, but everyone else who didn't, what were their beliefs about cancer and childhood cancer? And I think the one that I mentioned earlier that surprised me the most was the very prevalent thought that children can't get cancer, right? And that root piece of information basically infiltrated every other action thereafter. Why would people bring a child to treatment if this is something that is because of an outside source, or this is not natural. There's no treatment for them. There's no cure for them. The financial piece of it went into the education piece of it. So for me, one of the biggest things that I think is working with the community and that point of contact and changing that core piece of knowledge, changing that so that the conversation opens and then allows you to provide more support, because you'll have rooted that this is something that can't be treated and this is something that we can do something for. So I think that's incredibly important. So I just want to thank both of you guys for coming and talking today. I think this is a topic that is critical. And as I said, I think this is something that is sort of at the core of everything that we do for cancer care, whether you are here in the US, we are in Kenya, we are in Thailand, everywhere in the world has these same problems. And the question is just understanding what is the core, what is the thing that is driving that stigma, that belief, that shame, because it infiltrates every aspect, right? People getting treatment, finishing treatment, survivorship care. So this is a topic that is essential for people to think about, talk about, and come up with relevant interventions that make a big impact, hopefully. So thank you all for attending today. And our recording is going to be available on the DGHI YouTube site for people who want to look at it afterwards. And I think we are on time. So, thank you all.